Hello, it's Anthony Chadwick from the Webinar Vet. I'm welcoming you to another one of our VETchat podcasts. We're very fortunate today to have Andrew Perry on the line from Eastcott Referrals down in Swindon. Andrew is a diplomat of the European College of Veterinary Dentistry, and we're going to be talking about cats today. I've just come back from ISFM, which was in Rhodes, and armed with some of my newfound knowledge, I'm going to hopefully not sound totally out of touch here, Andrew, when I ask you some questions, and maybe find out how you're approaching cases, what sort of equipment you're using, and some advice for us when we're out in practice. What are the things we should be doing and what we shouldn't be doing?
Sounds great. Thank you very much. And thank you for having me today.
Oh, well, great to meet you. And obviously, I know you're from the Cotswold Hills originally, but I think there's always a little bit of Scouse in you if you spent 5 years in Liverpool as well, isn't there?
You never lose it, right? I'm very proud of my Scouse upbringing. So yeah, I might even verge on Scally intermittently.
All good. Well, from a boy who was born in Anfield, it's great to have an adopted Scouser on the podcast. I was at Rhodes. I'm showing off now. Had a week in the sun, and then I've come back. I think I brought the sun back from Rhodes. We're in the middle of some really lovely weather at the moment, and there was talk at the conference about FOPS, feline orofacial pain syndrome. Is that a condition that you see very often in your referral practice?
So I guess the simple answer is we are lucky in many respects. We don't see FOPS hugely frequently. It is a horrible disease. It really is. There's no question about that. And you know, the patients that do come to us with true FOPS can be extremely challenging to manage. I guess I say true FOPS because orofacial pain syndrome is probably, I think it's fair to say, as a syndromic disease, it's not probably just one single pathology, and it's a complex disease, and it's definitely a disease of exclusion. So, you know, to a certain extent, we're giving it the sort of Gallic shrug by the time we get to that making that diagnosis. I'm sure they talked about Burmese cats at Rhodes with you. I'm a Burmese cat owner myself. I have a small troublemaker that might come and photobomb any second in the typical manner.
Yes.
But sadly, they're definitely hugely overrepresented in true orofacial pain syndrome, and there's presumably some form of genetic component. Some have suggested that's a nerve channel gating defect, and potentially that these nerves are overly sensitive, and essentially you get all the classic symptoms of nerve pain. So you get allodynia, hyperesthesia, these phantom shooting pains, and patients will self-traumatize. I have sadly seen patients self-traumatize so badly that we've ended up euthanizing them because they've injured their tongue so extraordinarily.
Yes.
So it is a truly disgusting thing to get, sadly.
Yeah, I think we saw a very similar condition in dermatology called acral mutilation syndrome, and I'm pleased I only ever saw one in my dermatology career, and battled, and in the end had to sadly put the dog to sleep. It was a Springer Spaniel, a lovely dog as well. But these pictures and videos that I saw at ISFM of virtually amputating tongues is, as you say, truly horrendous, isn't it?
Yeah, absolutely. And the scary thing is that although in many of the more severe cases you'll see some symptoms or some potential triggers earlier on in life, especially when they are rotating their deciduous to adult dentition. But in some cases, the first signs that you can see of this type of presentation, at least, is when they have either dental trauma for some reason, and a common cause of dental trauma is us. You know, if we go and try and deal with tooth resorption, for instance, and you do everything by the textbook and you do a beautiful job, and you are delicate with those tissues as you possibly can. If those individuals have a predisposition to the development of orofacial pain syndrome, that can be a trigger. And And it can be really
Yeah.
scary because you have a cat came in for a simple, periodontal therapy, and suddenly you've got a cat that wants to self-mutilate.
And quite understandably, the client kind of points the finger at you because everything was okay until the dental happened.
Absolutely, and we all have those feelings of guilt and what did I do wrong and all of those kind of things.
Yeah.
And I think that's one of my sort of top tips, I guess, is that if you are dealing with a patient, certainly that has Burmese traits or is a Burmese cat,
Yeah.
you are very sensible to warn owners before you undertake any dental treatment that this is an individual that has an increased risk of these problems. Things like local anesthesia and regional anesthesia obviously can help reduce that sort of trauma or surgical sort of neuropathic sort of wind up, essentially. Drugs like ketamine as part of the anesthesia combinations. Gabapentin, amantadine, those kind of products are also really helpful post-operatively for cats that we feel are at risk. And certainly if you have a case that you are highly suspicious is developing or has developed orofacial pain syndrome, but has significant dental pathology, they can be linked. Unfortunately, you've got
Yeah.
just oversensitivity, and most cats show relatively minimal signs of oral discomfort with standard periodontal diseases. But if you've got orofacial pain syndrome, it makes everything so much worse. So
Yeah.
sometimes in those circumstances, we'll end up actually trying to manage the pain before we manage the disease. And that seems a bit counterintuitive because most of the time we manage the disease to eradicate the pain.
It was really interesting at the conference again. We used to talk about, again, bringing it back to dermatology. I know this will be upsetting any dentists that are listening, but we talked about feline psychogenic alopecia. And as you ruled everything out, you realized it was a very uncommon disease. But then it was really interesting at the conference. We had Claire Ruxbridge, obviously neurologist, Danielle Gumbor, medic, Sarah Heath, a behaviorist. And actually, in a lot of diseases that we see, especially in the cat, there very much is the physical, but also the mental element of disease. So, feline idiopathic cystitis and so on is obviously has a huge component, as it sounds like, potentially FOPS does. Some cats just cope with pain differently than others, don't they?
Completely, and and again, we would use things like amitriptyline in the management of FOPS cases in some instances,
Yeah.
because it has both effects on neuropathic pain and obviously on your levels of anxiety or an individual's levels of anxiety. So no, I think that you have to look at these patients very much holistically, but I definitely agree. As a diagnosis of exclusion, I wouldn't jump to this a conclusion of diagnosis of FOPS, especially in breeds that aren't particularly at risk, so domestic short hairs, those kind of groups,
Yeah.
without ideally ruling out a number of other possibilities. And certainly in our clinic, we've had patients referred for investigation of FOPS where we found meningiomas, otitis media, a couple with thoracic pathology, and even can sometimes present with sort of cholecystitis type symptoms. Cholecystitis causing sort of that bruxism and general, discomfort and, just trying to get all that tied together, really. So I wouldn't necessarily jump to the conclusion of a FOPS diagnosis in a patient that is not a at-risk breed.
And this needs obviously a very thorough workup as to make that sort of diagnosis of exclusion. Obviously, MRI, CT, radiography, all those things sort of come into it then, don't they, to help with the diagnosis?
They very much do, yeah. So, dental radiography is, as usual, the cornerstone of all sort of investigative steps when we're looking at dentistry. And, sadly, I know, I'm sure many of your listeners have probably been to dentistry lectures before and will have heard, the sort of mantra of X-ray, X-ray, X-ray. The truth is that is undoubtedly the case. We probably, we absolutely rely on dental radiography to help us in day-to-day cases. If we're looking at cats specifically, I now, in good conscience, wouldn't undertake, dental treatments on cats without dental radiography, because I know how much I'd miss, and I mean miss as in the presence of disease. And so, yeah, you're trying to operate blind. You're trying to operate without all the information, and that's impossible. And uh, I don't know what the equivalent in dermatology is, but I'm sure that orthopedic surgeons, no matter how cavalier you are, you're not going to try and fix a femoral fracture without a radiograph. Well, sadly, the same applies to us.
So we're peppering this podcast with tips. We've had the Burmese tips with FOPs, obviously, with radiography or with any cat dentistry. We should do radiography first. Again, interestingly, I'm sort of now on the other side of the fence in that I don't practice, but when I was doing dentistry, we could do some sort of basic radiography, but obviously, I probably wasn't doing it at the level that I should have been. What do you think about these cats that come in, with a little bit of gingivitis? They don't seem to be in pain with it. I think you were saying before about how some cats, you can look at their mouth and there seems to be minimal pain. I always used to say, well, this mouth must be painful. I had a tooth removed during the pandemic, which was really sore. Helps you to understand the pain, but do cats in some ways maybe react differently to that sort of gingivitis state, or should we be really thorough with cleaning? Should we be using, food that helps to clean teeth and things like TD? What's your thoughts about maybe before they come to you, the sort of early cases? How should we be dealing with those?
Yeah, I guess the simple truth is that it depends what diseases you're talking about, and I guess that's one of my own personal little bugbears, that orthopedic surgeons, again, I rant at orthopedic surgeons. Orthopedic surgeons don't refer to a lame dog as having an orthopedic, and they don't say, "Come on
Yes.
in, we'll
Yeah.
we'll do an orthopedic on you, or we'll do a dermatology on you."
Yeah.
Dentistry, just like all the other specialists, has multiple diseases that we treat.
Of
Now,
course.
if you look at gum disease, and periodontitis in cats, gingivitis is probably not uncomfortable for the majority of cats. Same go for people. Most of us will have at some point some degree of gingivitis. You're brushing your teeth, you get a little bit of blood on your teeth, or you haven't flossed for a few days, and then you floss. You'll definitely get some bleeding when you're cleaning interdentally, and that's gingivitis. Are you in pain? No, you're probably not. But what gingivitis is an indicator of the presence of increasing plaque levels and the likelihood of development of an associated disease. And the problem with cats is that they don't tolerate, in the vast majority of cases, brushing. So, diets and chews and those kind of things are great, and I actively would encourage them, but they may not fully, limit plaque levels to the point where you can manage gum disease effectively. And certainly in at-risk groups where you have, let's say Maine Coons, those kind of group breeds that are really prone to this early onset aggressive, what we call acute periodontitis. So you get cats that are 2 or 3 years of age that have gum recession, wobbly teeth, teeth that are falling out, all of those kind of, they're extremely challenging to manage in real terms. I think that there's no easy solve with gum disease in cats for much of the time. Tooth resorption might be associated with gum disease. So we know that there are two sorts of tooth resorption. Type 1 definitely is associated with gum disease. Type 2 definitely isn't. And again, genetic component, we know it's a really complex condition. You get, changes in the sort of receptor activity at a cellular level that upregulates osteoclasts and turns them into odontoclasts, and they start eating away at teeth. And again, diet, etc., is not going to necessarily help that. So it can be really difficult to sort of palliate these conditions in many respects in cats.
Those cats, as you say, with the Maine Coons and others I often saw with the Siamese as well, the very red
Yes.
teeth, they're starting to come out. Do you sort of approach that often as sort of a whole teeth removal, or do you do that in stages, sometimes take some out and then come back a year later to take others out, or how do you approach those?
So I guess the simple answer is it depends on what we believe is the underlying disease process.
Yeah.
So, and we would definitely differentiate between what we would term acute periodontitis and gingivitis stomatitis.
Yeah.
Gingivitis stomatitis, our first line treatment recommendation is always going to be elective extractions. Elective extractions doesn't mean full mouth extraction. That means identifying those teeth that have normal or normal plaque levels, or normal, within reason plaque levels, but have inappropriate gingival inflammation. And those individuals are always going to have caudal mucositis, so they're going to have inflammation of tissues beyond the mucogingival junction. So they might have glossitis, palatitis, but they will always have caudal mucositis. And in those individuals, elective extractions, definitely the best bang for your buck. 35% of those are going to get better like you fix them within a month. 35-40% are going to get better, but they might need some supportive therapy for up to 12 or 18 months. Because just like with nerves, if you get wound up immune system, it can take a very long time to settle down. So we wouldn't necessarily expect to see an immediate resolution. And then 20% or so are going to improve or get better, but not get to the point where they can come off medication, and they're going to need ancillary patients, or a percentage of that group is probably going to form true refractory cases, and they're really challenging to manage, as we know. Now, if you've got acute onset periodontitis, you've got really early onset inflammation, then I'd often do a swab at that point to check and see if they've got calicivirus. If they do have calicivirus, I'd be really worried that this is going to be a case that's going to progress into gingivitis stomatitis. And certainly the prognosis for management of gingivitis stomatitis is more guarded than if you've got acute periodontitis. Acute periodontitis, you might have really, really localized severe inflammation that's perhaps inappropriate to the level of the plaque on the tooth surface, but you're not going to have the stomatitis. You're not going to have inflammation anywhere else. And as soon as you take those teeth out with active infections around them, that gum is going to heal very readily, and they're going to get better incredibly rapidly. And so, in short, if you've got severe acute periodontitis, yes, you may end up doing full mouth or extracting all of the teeth, because all of the teeth have disease. But I wouldn't extract teeth that didn't have disease. But I would warn owners that in the longer term, this individual's probably at risk of developing periodontitis. It may be very difficult to prevent onward progression, and regular checkups, regular professional cleaning, and sadly, further extractions are almost certainly going to be needed.
With the Calici cases, would you use antivirals on those?
Great question, in the sense that, so there's limited evidence to suggest the benefit of antivirals for management of gingivitis stomatitis. The one good recent study by Henne and team was a relatively small cohort, but it was a nice double-blinded trial and prospective study. So it's pretty, scientifically rigorous, and they didn't show any statistical benefit to using interferon, and it was interferon antiviral that they were using. They did in individuals, owners and sort of total mouth inflammation scores did decrease, but not statistically significantly. So, to be honest with you, when we get to the stage of considering use of interferon, which is probably in these more refractory cases, we're not so worried about whether or not it's going to be beneficial. Hugely, it doesn't do any harm, and for some individuals it seems to be beneficial, so we will often use it, but it's not a frontline treatment, and I would not expect miraculous resolution with use of interferons. If you're interested in new stuff, there's excellent evidence in these truly refractory cases that stem cell therapy could be really beneficial for at least half of those cases, and certainly that's a technique that we're working in partnership with Edinburgh University, and sort of matching some research work that was done in the US, using allograft or fat grafts essentially to generate stem cells and then return to these patients.
Did you know the Webinar Vet has a public community Facebook group? We want to ensure veterinary professionals have a place to stay in the loop with everything that's happening here at the Webinar Vets. In this public group, you can chat and network with other veterinary professionals from across the globe, get exclusive updates, content recommendations, and so much more. Pop and say hello to a community of over 2,000 veterinary professionals by searching the Webinar Vet community on Facebook. Fantastic. And I suppose all the work with monoclonal antibodies, in other inflammatory diseases like osteoarthritis and obviously dermatology, atopic type diseases, I presume, there's a potential there for dentistry as well, isn't there?
I think there is, and I have heard people and manufacturers of monoclonal antibodies proposing that these could be really beneficial. And if anybody wants to do a trial out, if any manufacturers out there listening, please contact me. I'm easily available.
Yeah.
But in essence, as yet, we don't have any clinical data. But again, I would. It wouldn't be something that I'd be very interested in exploring further.
Perhaps if we can move on, just talking about, because we've mentioned it about radiography and so on, and the tools that we need perhaps to do good dentistry in practice. So if we can maybe start by talking about imaging, what do you think as a first opinion vet, GP vet, should be the setup for doing dentistry, maybe from the imaging, and then we'll move on to the kit that you use to actually clean teeth and remove them and so on.
Yep. I think it's not an understatement to say that dental radiography is a critical component of doing good quality dentistry, and so I think undoubtedly is a massive portion of it. I personally, wherever you can, would always recommend chairside operations. I think whenever you have to, take a patient from the area that you're doing dental treatment in and take them to an area where you're going to x-ray them and then bring them back again, or you have to take an x-ray, take it somewhere else to develop it and then bring it back again, it adds a degree of faff, and I don't deal
which
well
stops
with,
you doing it then.
Yeah, absolutely. We all know that we're busy, super busy people, and to quote the internet, ain't nobody got time for that, and so you definitely don't end up doing as many radiographs as you should. And the truth is that we would always do full mouth radiographs in all of our new feline patients, and anytime that I have an issue intraoperatively, I take an x-ray, and we might take 20 x-rays of an individual patient. If you and we think that that's really important. If you don't have that ability, or you have to, there's something that's going to interfere with your workflow, slow the whole process up, and it takes 20 30 minutes to do a full mouth series, that's not efficient, appropriate, or going to be used enough. So
and it also keeps the cat or the dog under for a lot longer with the anesthetic, which increases risk, doesn't it?
Absolutely. And most of these patients, dental diseases are more common in older patients, and you get more comorbidities. And so, of course, anesthesia time and anesthesia stuff is critically important to many patients with dental disease. So I really like, I don't have a problem or a difference in, I think that any of the chairside systems are absolutely great, but I do think it's really useful having the ability to take x-rays where you're working. And I would always, if you have the ability to have a fixed area, then have a wall mounted x-ray generator. It just gets in the way far, far less and allows you to work around the patient really efficiently. I think that the CR systems, so these are the indirect digital systems, are probably easier and more amenable, and perhaps even more have greater crossover in general practice than the direct digital systems. The downside with the direct digital systems is that the screens, the sensor size is relatively small. You're going to get one. They're really expensive. If you damage it, it's like £5,000 to replace. Whereas the indirect system, although it's a little bit slower initially, because the screen sizes are bigger, you can often take more teeth on one image. So actually, it all evens out. I think the quality of the DR systems is excellent, but the CR is very, very good. And so, yeah, for most people in general practice, I would recommend the CR systems, and the CR7's an excellent, workhorse basically.
What about some of the handheld machines? Have you seen them being used?
Again, I guess we've got to separate the two things. So you've got an X-ray generator, and then some form of capturing that X-ray data, and then extrapolating that to a digital format. And so X-ray generators, essentially, they're all much of a muchness. They just, you're either going to have wall-mounted, floor-mounted, or handheld unit. I've used the handhelds actually doing wildlife dentistry. I've used them on lions, and so they've got plenty of punch, and they work just fine, and they are really very safe. I think the downside, so the massive benefit is if you've got a multi-center site or multi center setup, and you're going to be wanting to do dentistry at multiple sites, and you're going to only have one system per site or per hospital. You can move that around. They're super portable, very, very easy. If you're a peripatetic dentist and you're going into practices, lugging around a full-size X-ray generator might be just too much hassle. So again, I know some people that have used tracking, but the truth is that the learning curve is probably much steeper initially with the handheld units. Um, you know, we end up doing these weird bisecting angle views, and it's all about calculating different angles of beams, etc. And when you're able to step back and somebody else is taking the load, the arm of the machine, it's much easier than when you're trying to eyeball it from behind. And so that's the downside of those units.
Yeah, brilliant. And then if we move on, I suppose obviously with your work, you're obviously also doing not just dentistry, but you're obviously investigating, as you said, for tumours, etc. So presumably on any sort of bone type work, CT is probably the best, but MRI you obviously need to use for neurology work. So I know you've got both scanners in practice. In a sense, some GP practices are going there because they're becoming more affordable, but this is probably where the specialist really comes into their own with this advanced imaging, isn't it?
I think so, yeah. So dental radiography is amazing for anything within the alveolar bone, essentially. So anything within the alveolar crest, you can probably identify with dental radiographs, and that's both the upper and lower jaw. But as soon as you move out of the alveolar bone into the sort of true mandible, maxilla, and beyond, sadly, dental radiographs are not much better than standard plain radiography, and CT is probably our go-to modality. We do have, as you say, MR as well, and certainly for sort of neuropathic or origin problems, we may end up using that technology. But the vast majority will tend to use CT first. It tends to be cheaper. It's definitely much quicker, and mainly I'm interested in bones and the soft tissues that I can see on a CT. In veterinary medicine, in veterinary dentistry at least, for specialism side of things, there's a big drive towards, or there's a lot of people now using the sort of the cone beam CT technology, which is a little less costly and a lot smaller than the conventional CT, and perhaps some of its benefits. It has a greater sort of slice. The slices that you can generate are definitely thinner, and therefore image quality is pretty fantastic. It's not so good for looking at contrast agents and those kind of things, and lungs, etc. And it's a relatively small field of view, so very good for just the head. So if you have a lot
Yeah.
of pure dentistry or trauma patients, then it might be great. But if you do quite a lot of oncologic surgery, then perhaps more conventional CT. But yeah, we use CT every day in our department, and obviously we do a fair bit of maxillofacial surgery. That's kind of my area of special interest. Pure, that's sort of beyond pure dentistry, really. But yeah, CT is wonderful. You can identify in cats, if they've had road traffic accidents, we know that you'll find twice as many fractures in cats than you if you're using CT than conventional. Looking at the temporomandibular joint, I don't know if you remember taking X-rays of temporomandibular joints and trying to.
Tricky.
It's just impossible.
Yeah.
And we used to dogmatically say that if you have a fracture of the temporomandibular joint, that almost certainly those patients were going to get ankylosis and they needed some treatment. And since the advent of CT, what we probably should have said is, if it's bad enough that we can see it on an X-ray, it's probably going to get ankylosis and probably needs further treatment, because we missed just huge numbers of much less severe fractures of the temporomandibular joint apparatus in cats, because you just can't see them on conventional radiographs, or it's really hard.
When you're dealing with cats, is it more catmatically than dogmatically? Or can you still use the word dogmatic when you're talking about cats? Should you not say catmatically? I just think you've got to be fair to cats here.
I don't think so. I think I'm comfortable with dogmatic in reference to cats.
Okay, fair enough. Just to sort of to finish off the imaging part, obviously I suspect you also get sort of pulled in for throat type things as well. Is there ever a need for ultrasound of throat or nose, perhaps to look for foreign bodies, or would a MRI or a CT pick that up? So is ultrasound a tool that you don't really need to use very much?
So yeah, we use ultrasound relatively commonly, and certainly as an adjunct, we'll often get called in for patients with pain on mouth opening. So a lot of those will have issues in the retrobulbar space, and certainly that's part and parcel of the investigations that we do. And we also, when we're doing oncologic staging, we use ultrasound guided lymph node aspirates. And obviously, lymph node aspirates of the mandibular lymph nodes are relatively easy, but one of the challenges is that it's a lymphocentrum, so you've got maybe between 3 and 5 lymph nodes per side. And then you've got the media retropharyngeal, which is the sort of the big daddy of the lymph nodes in the head and drains the entirety of that area. And we always like to take an aspirate or a biopsy from that as well when we're doing oncologic staging, and it's quite an invasive surgery. It's quite straightforward, but you're right next to the internal carotid artery. You can kind of wave at it, and some other pretty significant.
Not one you want to hit.
No, it's got a name. You don't want to cut it.
Yes.
So yeah, it's if you can use aspirates and ultrasound guidance, then it's fabulously useful. And yeah, absolutely, our amazing imaging team at Eastcott are pretty good. They've done a lot of those over the years.
So it's, as you say, it's a whole spectrum of imaging then, really, isn't it?
Yeah, absolutely. And the head is quite a complex area, is the simple truth. And as soon as you move outside of the immediate jaws, then it gets pretty complicated pretty quickly with a whole range of different tissues, and therefore you've got to bring all these different imaging modalities to bear depending on what you're looking for.
Finally, I've really enjoyed it. I suppose we're moving on to an area that is really important. I'm not sure it's as topical as it should be, but it's an area that really interests me. The use of antibiosis, particularly with tooth extractions, gingivitis. What is your thoughts around that? What do you do, within your practice, and what would you recommend a general practitioner to be doing?
Yeah.
Do you swab at all and things like that? Maybe just talk us through.
Yeah. So We do swabbing, but not routinely. Swabs from oral cavities are probably not hugely beneficial for the general sort of oral pathogens. And we actually know that quite a lot of the bacteria in the oral cavity aren't actually culturable. You know, we've used now DNA markers, RNA markers, huge amount of work's done by Waltham, and thank you to them, looking at the microbiome of the oral cavity in cats and dogs. And the vast majority of them you're not going to pick up on a culture. So no, we don't use culture very frequently. Where we would use culture is if we have some form of chronic infection. We've got osteomyelitis, those kind of things, and what we would tend to do would be to take tissue samples and send for tissue maceration and culture. So we don't really use swabs very much at all, is the simple answer. From an antibiotic point of view, we definitely do use antibiotics, but we use them pretty infrequently. I would say that the vast majority of patients are going to not receive antibiotics. So if we have our sort of general guidance really would be we would use intraoperative intravenous antibiotics more frequently than antibiotics that we would prescribe for post-operative or pre-operative therapy. So a good broad spectrum cephalosporin, cephalexin type product or potentiated amoxicillin tends to be our go-to, and we tend to use that in individuals that have potential for comorbidities that will cause immunosuppression. So, you know, any of the sort of diabetes, those kind of issues, anything that is going to put you at greater risk of developing an infection. People often worry about sort of bacteremia that is associated with toothbrushing, with you know, having periodontal
Cleaning
therapy.
extractions.
The truth is that you get a bacteremia. If you've got gum disease, you get a bacteremia every time you eat something, let alone every time, you know, someone does a scaling and polishing. Your immune system is really, really good at picking those bacteria up and has been seeing those daily for months and months in most circumstances. And we don't give antibiotics every time we you know, eat something. So the truth is it's unnecessary for the vast majority unless there's this immunocompromised condition or you've got a comorbidity such as, you know, renal disease, heart problems, etc., etc. And we would use IV antibiotics then. If I've got a patient that has really terrible periodontitis, has got deep pocketing, I've extracted teeth, there's been a lot of extractions, I might consider a relatively short course of antibiotics, but that would be in conjunction with other therapies. And so just like anywhere, you know, that guy Halstead with his principles, he knew what he was talking about. And it applies in the mouth as it applies everywhere else. You debride necrotic tissue and infected tissue. You close dead space without tension. And that's what allows tissues to heal rapidly. And if you apply that, you don't need long courses of antibiotics. You know, you lavage out infected tissue, etc., etc. So, you know, those principles should be applied. So again, I don't use things like clindamycin very often. And if I've got an osteomyelitis, as I say, those are the circumstances where I would take culture and send off, or take tissue, send that for culture, and then use antibiotics depending.
Wait for
Exactly.
results.
Yeah. So the simple truth is we don't use them very much. We definitely don't use long courses very often. We almost never give pre-operative antibiotics, and we tend to use a relatively small grouping of drugs, and certainly amoxicillin or a potentiated amoxicillin it is probably perfectly acceptable for the vast majority. And if you've got a really nasty osteomyelitis or some sort of more aggressive process, then you know, we would use metronidazole most commonly in adjunct with you know, that potentiated amoxicillin basically. But I've not dispensed Enrofloxacin. I guess I'm talking to a dermatologist. I've not dispensed a fluoroquinolone for 10 years. Never had the need to. And intermittently, we have seen patients with MRSP cultured from the oral cavity. And quite often we'll stop all antibiotics at that stage, and we'll just use chlorhexidine oral rinses,
Washes,
because MRSP is super sensitive to chlorhexidine.
yeah.
And then you just let the normal bacteria recolonize the oral cavity, and they'll outcompete the MRSP. And in the vast majority of cases, it's much less scary than you think.
And I presume with cats, that might have almost come from them licking their skin where the MRSP was,
Yeah.
rather than them getting it, in their mouth
Absolutely,
per se.
yeah. It's not going to be a natural, or it's going to not be a common pathogen of the oral cavity. And yeah, I think you're absolutely right.
Mike Willard, who's a famous gastroenterologist who's done several lectures for us, and I love Mike. He says, what I told you 10 years ago was a lie. I just didn't realise. And it is very true, isn't it? I spent a lot of time doing dentals, and they were dentals. You know what I
Yeah,
mean?
no, don't worry. It's common nomenclature. It's totally fine.
I know, and it's terrible. I absolutely agree with you. Dental procedures. And they were really satisfying cases, because often you would, at that stage, have people they'd come to me and they'd say, but I've been to another practice, and because the dog is old or the cat is old, they've said not to bother. And you looked at the mouth and you thought, this has to be in pain, this dog or cat. And you actually did the procedure, obviously gave antibiotics, and a week later the cat or dog came back and they said, he's 5 years younger. So they were such satisfying cases. But of course, it was very much the procedure rather than the antibiotics that was doing the good work, so to speak.
But in truth, a lot of people ask me with that sort of quizzical. I go back to reunions, and people look at me and go, "Are you a dentist? Why?" Just because most of us sensible vets don't enjoy dentistry necessarily, and and one of the big reasons that I became a dentist was actually just exactly what you've said. Is I felt that I could have an impact on my patients' welfare, probably more than almost any other thing that I did on a day-to-day basis. Um, and I'm not really great with delayed gratification, so I'm no orthopedic surgeon. And yeah, I 100% agree with you. There's so many patients out there that are, they're suffering in silence essentially, and because it's a slow onset disease, it's a bit like obesity. Slow onset disease. You don't see big changes, and it's really only after you've done something about it that you get that
You
sort
see the
of payoff,
difference.
basically. So, yeah, really challenging.
Final, very quick one, again, with my experience of having my own tooth taking out. I was very much, I would remove a lot of teeth in these Yorkshire Terriers or cats that came in, with really bad mouths. And I tended never to stitch those holes, because I almost felt that the stuff needed to drain out of them. And then newer, younger vets came in and were very keen on stitching gums. I went to my own dentist, they took quite a big tooth out. Obviously, they were worried about dry sockets, and they packed it for a day or two, but actually they didn't stitch either. So again, as the fashion for stitching, is that still a big thing in dentistry? Or tell maybe a 2 minutes, what should a GP vet be doing with regard to stitching gums and sockets and
I'll do
so
my
on?
best to keep it short. I appreciate, evidence to date probably indicates that I'm not going to, but I'll try. So in short, we use quite a lot of, we stitch the vast majority of our oral wounds.
Yeah,
And when you had your tooth extracted, you were probably given a cotton pledget, and they stuck it in the hole and they said, bite on this for the next half an hour. And you, I'm sure, complied brilliantly. And
yeah,
then they said, okay, well, tonight and tomorrow, you do nothing. You don't chew on that side. You don't eat on that side. If that clot comes out, I need to know. You need to come back and tell me. And
yeah.
then they said, you're going to rinse your mouth twice daily with a salty water solution. And if you have any, excess pain and discomfort, you come straight back. My patients are rubbish at doing all of those things.
Yeah,
And so in humans, they tend to find that human patients find oral sutures very irritating. If you look at our homunculus, our tongue is massive. We're really good at, oh God, that feels weird. And essentially, they get more complaints because they put sutures in. They use silk, so most commonly they'll have to
yeah.
take those sutures out. Um, because my patients are really terrible at looking after their extraction sites, I would prefer to suture, because I think it increases the speed of healing, decreases post-operative pain, reduces the likelihood of hemorrhage, definitely I think reduces the risk of development of dry socket or osteitis. And in the vast majority of cases, I don't like being woken up in the middle of the night. And so, if you've got a dog that starts bleeding, that's difficult. And then you're in that difficult scenario. So no, I'm a big fan of closing oral wounds. There are a couple of instances where I might choose not to, and I might place just some simple cruciate sutures over the defect just to pull the wound edges together, but I wouldn't raise a flap necessarily to try and close that. So the classic would be as if I've extracted the maxillary first molar, but not the maxillary second molar, and I've got a maxillary fourth premolar. That's quite a big defect, and you have to create quite a large flap, and in doing so, you can infect the gingival attachment of the fourth premolar, predispose it to gum disease. So in those cases, I might not choose to close it definitively, but yeah, just place a couple of sutures just to hold the clot in a bit better.
Brilliant.
Was that 2 minutes?
Andrew, that's been fantastic. Yeah, that was good. It's been great. Charlie's probably shouting at us because we have gone on, but it has been so interesting. I hope people listening to it find it as equally interesting as I did, because of course dentistry, particularly in cats, I think they now say, I remember us doing a series on cats and everybody vied. They were experts each on cats, and everybody vied for what was the most important disease. Obviously, the dermatologist thought theirs was, then the orthopod thought theirs was, but dentistry is right up there. I think the orthopod brought out some evidence-based medicine that suggested that they were the most important, but these orthopedic surgeons always think that anyway.
What's the difference between God and an orthopedic surgeon?
There isn't much of a one, is there?
Well, God doesn't think he's an orthopedic surgeon.
Very good. To finish off, we all know God loves dentists as well, and dermatologists. But Andrew, it's been great to speak to you. I know how busy you are, so thank you so much for giving me the time to do it. Take care. Bye-bye.